Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by your friends at Firefly Health. We would like to remind you that the chat feature is available, so feel free to send in your questions for the panel throughout the discussion. Our speakers would love to hear from you. And with that, I will turn it over to our moderator, Jessica Bartlett.
Hello, welcome to today's panel hosted by Health and sponsored by Firefly. Today, we're talking all about virtual first healthcare, what it is, why the market should pay attention, and why more of us are leaning into this new plan design. We're going to get into all of that. We have time for audience questions at the end, as they mentioned, which you can submit throughout the program through the chat function. But first, I'd like to introduce you to our panelists. If you could all join me on the screen. Welcome, welcome. So Faye, kick us off. Tell us a bit about you and your company.
Happy to be here. Thanks, Jessica. I'm Faye Runtberg. I am the CEO of Firefly Health, and Firefly is at its core a virtual first advanced primary care and coverage provider. And our evolution really started in the beginning as virtual first advanced primary care. We then build out a Firefly nearby network, so tightly integrated physical facility partners and navigation capabilities. And we also have a health plan built around our offering, but we partner with carriers as well, including Blue Cross of Massachusetts, and you'll hear from Ashley today in providing virtual first care via carriers, as well as selling directly to employers.
Thanks so much. Kevin?
Thanks, Jessica. Great to be here. Excited for the discussion. My name is Kevin Fayak. I lead innovation and commercialization for North America here at Aon. For those of you that don't know, Aon is a leading professional services firm. We have businesses within risk, retirement, and health solutions. I sit within our health solutions business. So we help organizations mitigate rising healthcare costs, improve employee health, well-being. So again, really excited for today's conversation and happy to be here with the other panelists.
Thank you so much. Ashley?
Hi, Jessica. Thanks. Happy to be here too. Ashley Yates Summit, emergency physician, family physician by background. And I lead our virtual care innovation teams here at Blue Cross Blue Shield in Massachusetts. We're Massachusetts' largest healthcare plan. I have about 3 million members located here within the state, but also nationally across the U.S. And delighted to be having this conversation today around these innovations in care that, frankly, were really accelerated and spurned by the pandemic. So looking forward to the conversation.
Excellent. Well, thank you all for joining me. I'm really excited to talk more about this. Let's start just by a bit of table setting, if you will. Faye, can you help us understand what is a virtual first health plan? Should we even be calling it that? Like, how do you understand what this is? Or how does the market understand what this is?
So I'm going to lead with a statement that might be controversial given the subject of this webinar, but I really don't like the term virtual first, even though I used it in my description of Firefly. I think that it's been very diluted through association with far more narrow solutions. And I want it to mean that virtual becomes an ingredient in all care, seamlessly integrated. And right now, I think that people just don't know what it means. And I think that the industry as a whole hasn't yet agreed on the tenets of what a virtual first plan should be, aside from providing broad discounted access to virtual care as part of the plan design. So at Firefly, I'd say that we believe virtual first plan should go beyond simply providing access to virtual care services, which done poorly could actually drive up total cost of care and result in a poor, fragmented member experience. And I actually think it should be a bridge system between all aspects of both care and coverage that draws the archipelago of disconnected islands, provider, payer, in-person, virtual, specialist, surgery, mental health, pharma together. And I believe that a risk-bearing advanced primary care should be at the core of this, ideally free to the member. It should be a truly patient-centric experience that empowers members and offers next level convenience through easy to use digital experience, and then navigates and guides them to other in-person services as well through hands-on navigation. It should be risk-bearing so that there is accountability on and more alignment in terms of outcomes, both quality and cost. And there should be an approach to in-person care services that involves a tightly integrated ecosystem of partners. I think that a lot of the problems we see from pure virtual care solutions is that as soon as a member leaves, they have to start over and they're on their own. And that's where costs add up. And that's where the member experience breaks down.
I mean, that's first of all, the word of the day. What was it? Archipelago. I don't remember what it was. Archipelago. Yeah. I'm going to add that to my list to try to include in stories. Thank you. I mean, so that's such a comprehensive answer though. So Ashley, how is Blue Cross interacting with these plans, or how has it come to be a component of the healthcare delivery that Blue Cross is offering?
Yeah, I would agree with everything that Faye said there. I think, if we were having this conversation 3 or 4 years ago, we would be thinking about virtual first and probably using the word telehealth. And like telehealth would be the thing. It would be what you were selecting as an alternative to something else. And I think what the pandemic taught us is that telehealth and virtual care, it's nothing but a medium by which to deliver care. And wow, what an opportunity this medium has created. Faye used the word advanced primary care. When I think about advanced primary care, I think about that split in the House of Medicine that happened years and years ago, where we had mental health services over here and everything else over there. And with advanced primary care, what it's really allowed us to do through delivering those services virtually is to really be able to bring all of those services back in under one roof. And things that I'm excited about what Faye's team is doing is top of license work. You've got the primary care provider that's working alongside dietitians, mental health clinicians, coaches, people that can do that follow-up to make sure that you understood what just happened in your visit and can connect the dots for you on where your prescriptions refilled. How can I help you get to that in-person care that you might need as a consequence to a visit with one of Firefly's providers. So it's really that opportunity to allow on top of license work. I think that brings some of the joy back in the delivery of care, but it also creates the access and the delightful experience for our members, for patients that struggle in this environment to get the care that they want and deserve when they need it, but also in a way that they can actually access it. And I think that's just so incredibly important. And it also allows the integration of some of these kind of digitally connected services, things like your glucometer, if you've got diabetes, and all of the power that opens up to empower you as a patient to be able to manage your health condition with the support you need. I happened to have my annual visit with my primary care doctor just the day before yesterday. And I thought back, well, it was exactly a year to the day since I saw him last. And then when I look at the touch points that Faye's providers have with their patients, up to 40 touch points or more a year, and just think about how that allows you to take charge of your health and to get those questions answered. There I was the day before yesterday, 3:30 in the afternoon. I still haven't eaten because when I went in a year ago, I wasn't fasting for my blood work, and I was supposed to go back and get that done during the year. And of course, I didn't get around to it. So I'm sitting there 3:30 in the afternoon, starving in the waiting room because I haven't eaten, because I really know I needed to get this done. And it would have been, just so much more powerful in the system that Firefly has created.
Ashley, we're here for you.
I know. You would have followed up with me and you would have said, Ash, what about that blood work you didn't get around to?
So we have a provider that's offering the services and insurance willing to cover it. Kevin, from the employer perspective, are employers really willing to offer this kind of thing, or is there still skepticism in the market when you think, primary care with a virtual first component? Like how willing are people to move in this direction?
Yeah, great question. And first of all, Faye, well done on the SAT words. So challenge accepted. We can all rise to the level of big words. I'm
not playing Scrabble against Faye.
That's right. I think the short answer is I think employers are very willing to try new things, right? I think it's important, and both Faye and Ashley talked about this. You almost have to, take a step back 10, even 15 years ago, right? Where there has been this amazing evolution of virtual primary care, from virtual urgent care. So Ashley talked about telemedicine, where we're thinking about multimodal visits, being able to, do text and video and phone to have your problem solved. I have 2 little kids, so using that to fill scripts, that was very sort of 10 plus years ago. And then we got into the second generation, which is virtual primary care, right? Which includes virtual urgent care, but now talking about more of a longitudinal relationship. But now in this evolution of virtual primary care with virtual first health plans or virtual focus or whatever language we'd like to use, now we're starting to talk about care coordination and data sharing and value-based payments, all the things that employers have asked about for so long, layering on technology. And we know coming out of the pandemic, and it's hard to have a discussion about this without touching on the pandemic, it's a situation where consumers are very willing to use technology. They want to lean into technology. There's all these great stats we can, rattle off about that very fact. But is there's convergence of willingness to use technology alongside evolution of virtual primary care. And I feel like now is the time more than ever that employers are saying, this is something I'm willing to try to pilot or to fully adopt because, we see this as the future.
We're going to get into the effects of the pandemic. I certainly want to touch upon that. But before we do, I want to stick on kind of what the promise and the challenges of this model might be. Kevin, sticking with you, I mean, Ashley had mentioned advanced primary care. You touched upon this too. But what about the basics? I mean, people are struggling just to access primary care at a foundation. So I don't has the use of virtual first primary care or virtual first plan designs just helped access issues from a foundation. I mean, amazing to talk about what comes next and what the advancements can be, but at a baseline, what has this been able to bring?
Yeah, I think we've talked about shortages in first line providers, primary care physicians, since I've been in this industry. And we know that spend for an employer, less than 10% of spend is around primary care, right? But we know that investing in primary care has savings, to almost like tenfold that'll touch other aspects of the plan more broadly. And I think additionally, when we think about for certain geographies, you might have, critical mass where you have a lot of primary care physicians. But when you think about the entire nation, we are so geographically, spread out that there's a huge access issue. And I think we need something like 17,000 primary care physicians to remove the shortage area designation set forth by the federal government. So the fact of the matter is, using a virtual approach, you don't have to have a conversation about who are the providers within my community that I can drive 2 minutes to, but who are the providers that I can see digitally for those, care continuum items that I can do the same way I would with an in-person physician. So to me, when I talk to my clients, we talk to our clients at Aon about how do we help address the access issue. This is one of the very first places that we go virtually to sort of bring care into the home.
And
I'll follow up on that.
Yeah, please.
You've touched a little bit on that concept of like a care desert and how the virtual care delivery allows you to see somebody that's just would not be geographically desirable in the prior world. But there's all of these other pieces, I think, as far as the access, because in that traditional model, right, you'd have to see that primary care doctor as the gateway to getting any of the other care elements that the virtual advanced primary care team can provide. So I probably don't have to see me as a primary care doctor when I could see the licensed mental health clinician in the practice or get that advice on my diabetes care from the dietitian. So you're opening up access beyond the care desert issue. You're opening up the access to a care team and a team that's able to work at the top of their license, which is solving that provider shortage issue. And then I think about what's happened with working from home, and now people that traditionally might have worked within 5 miles or 10 or 15 miles of the office building and had their primary care doctor within that circumference or radius, who are now living in another state or spending half of the year living somewhere that's remote to where their office is, and hence remote to where their primary care provider is. And they don't have to get a divorce from their primary care doctor because they moved to another state or they've moved to maybe an area that's just more affordable than a downtown urban core. So there's so much around that access conversation that's nuanced. And then lastly, what I would say is when I was trained as a primary care doctor, I remember 2 sort of key elements of the training. One was 80% of what you will need to effectively provide care to your patients is going to be through the history. The history is a conversation, and that conversation, like we're having here today, can be done virtually. It's just as a provider, I never imagined that I would be doing this in the same way that I'm interacting with so many other elements of my life. And so being able to really concentrate that history in this virtual realm really opens up just a whole lot of opportunity, not to not provide the in-person care. I know Faye's going to talk about how Firefly seamlessly does that, but really allows that interaction to occur. And the other piece I was taught is about a third of what you're going to do as a primary care physician has got a mental health overlay to it, or is actually firmly grounded in mental health. And when that mental health support isn't available in the practice, and it is available in an advanced primary care model, wow, as a family physician, I'm able to provide much more comprehensive care. And when I can provide that care comprehensively, I know the outcomes are better. I know the quality of the care that's delivered is better. I know the medication compliance and the compliance with treatment plans is improved. And ultimately, that leads to more affordable healthcare. And we have an affordability crisis in this country right now. And so that, to me, is some of the great promise of this.
Yeah, Faye actually touched on some of this. It almost got to the idea of provider burnout, the idea that you can't do all of it yourself within a physical practice. And I wonder, from a provider side, what has this technology and the progression of it meant? Like, has it addressed burnout? Has it helped better coordination among providers who maybe don't have to exist in the same space? Like, what have the benefits been from a provider perspective?
Yeah, I think it's threefold, and probably many more folds, but I'll talk about three of them. One is, as Ashley mentioned, it certainly in our model and others that are team-based, it really enables you, to focus on whether you want to say top of your license or really on your area of expertise. So, you as an MD have a lot of people with, whether they're coming to you purely for a behavioral health reason, or behavioral health is a comorbidity and a driver of the vast majority of chronic conditions, and is a chronic condition in and of itself. And, as an MD, that is not where, you're probably best suited to be focused. And if you have a behavioral health specialist on your team, then it means that that your patients are able to have those things addressed, and you can focus your time on the more complex conditions, relationship building. Same thing with having an MP to support you and really serve as a quarterback with that patient. So I think there's an element of being able to focus on what you do best that enables you to scale yourself, and also is reassuring because you know that your patients are getting the care that they need. It is more scalable. There's also, I think, a joy that we see from many of our clinicians that they're really able to practice in a way that aligns with why they went to medical school in the first place, which is to really follow a patient and provide care that they know results in excellent outcomes, real quality improvement. And in a traditional system, that's so rarely the case. You just don't have the opportunity to truly provide longitudinal care. It is truly visit-based, and even a PCP who, is, accountable for a member and sees them annually, it's once a year. So you're really not managing actively conditions. And, Firefly enables true longitudinal visibility, and you're able to go from end to end and see that improvement. I think that's really satisfying. A lot of burnout comes from people doing tasks that they know don't result in high value care. So they're doing things, having people come into visits that they know don't need to happen in the first place. It could have been an asynchronous chat or a care plan, or could have happened elsewhere, or spending all of their time in administrative work that has nothing to do with the actual provision of care themselves. So by wicking away that and really aligning the work with the outcomes, I think it's just much more rewarding.
Ashley, is this fundamentally saving money? I mean, because so much of the conversation around telehealth, at least during the pandemic, was about physical providers switching to a virtual method. Now, that was still fee for service. This is a different reimbursement model. And so does it have to be grounded in affordability? And is it currently a more affordable option?
Yeah, so I mean, I think everything that we do and everything we drive towards in healthcare needs to be grounded in affordability. If we're going to have a healthcare delivery system that's still there for all of us as we age and need care and manage our own chronic conditions as they develop. I think we've looked at grounding this in affordability. Blue Cross founded that AQC sort of model of care that's grounded in outcomes based. I think time will tell as we look at this model, but there's a lot of hope there. If I look at some of the data that, and not just Firefly, not just primary care, but even in the specialty care realm where there's been virtual care delivery, these are pretty impressive numbers, both in terms of speed and number of patients within a practice like Firefly that have brought hypertension under control, that have got their hemoglobin A1C under control. And what I do know is that if you can get your hemoglobin A1C, your diabetes, or your hypertension, your blood pressure under control, that is going to lead to better health outcomes, fewer complications, and a lower cost of care down the road. So it's one of the reasons why we're very seriously looking at virtual care delivery promise at Blue Cross Blue Shield, and it's why we engaged early on in the conversation with Faye and the Firefly team because of the outcomes that they're seeing and how that ultimately translates into an affordability conversation. Also, Firefly was willing to have a conversation with us about taking risk on care. And when you take risk on care, you're taking accountability for the member's health. And ultimately, it's a different conversation than straight fee-for-service modeling. And so with that and recognizing that this was new and members want, they need a little incentive maybe to get there and to try something, we did two things. We did not create a virtual only plan that you have to lock yourself into for a year. Firefly is a provider in our network that a member can select. And you know what? It might not be right for them. And they might choose to go back to a more, I hate this term as well, but we use it in the industry, a bricks and mortar primary care practice. They can make that selection just like they can select any other healthcare provider. But because we anticipate that the outcomes and the overall cost of care will be reduced in the model of team-based care and that collaborative care model of advanced primary care where mental health care is part of this, we're able to pass along that what we anticipate will be a decreased cost of care to members through a $0 copay for those employers that have elected the $0 copay construct for virtual care delivery. So this truly is more affordable for patients in the moment and driving towards better health outcomes. And to me, that's what value-based care is all about.
I mean, so clearly there are a lot.
Jessica,
Please, yeah.
if you don't mind, just from Ashley's comments, I think I really want to underscore the importance of care coordination and technology being paramount to why there's even the potential for cost savings, right? And I think we believe that there is significant monies to be saved by a model like this, but it's running the gamut from reducing unnecessary services, right? When you're focusing on care coordination, you can steer people to, certain imaging facilities, steer them away from the emergency room, have the captive audience to steer towards lower cost, higher quality care, be in that position to better manage chronic conditions, just like Ashley said. And then again, when you start leveraging technology, and I even see there's questions in the chat around artificial intelligence and how can we leverage AI, there is boundless opportunity to use emerging technology, NLP and others, and even things we've had for a while, like remote patient monitoring. Ashley and Faye both talked about that. So it's not just one thing that's going to potentially lead to cost savings, but the broader care coordination and the broader technology coming together, I think, promises pretty significant efficiencies.
There's so much promise in this, but maybe this is my journalism roots showing, but I'm also deeply skeptical of new things in healthcare. It takes so long to implement. There's such a slow uptake to changes in the model. And again, we'll talk about whether the pandemic has just kind of like moved us with force into this new world. But I also want to acknowledge some of the challenges of moving to scale into this kind of model. And Kevin, sticking with you, let's talk about the demographics of this. Are all of your employees and your employer members open to this, or is it really a trend along demographic lines where you might have elderly patients who are saying, you know, I'd rather not see my PCP virtually. I mean, in fact, they want to see, I mean, kind of who doesn't, one PCP for their entire lives across the continuum. But I don't know if maybe a younger population is more open, or maybe older populations who see the doctor more frequently are open. So like, are there demographic aspects to this that need to be overcome?
I think there are to an extent, Jessica. I think we've done a fair amount of consumer research within not just virtual first health plans, but just virtual primary care more broadly. And I think what we found is, you know, about 1 in 4 consumers would be happy to switch their PCP to be a virtual one. And I think the other interesting thing is there are a ton of use cases where people are regularly using virtual care, even outside of one of these models, from regularly seeing mental health professionals, regularly utilizing some type of virtual model for urgent care, like I talked about before. Of course, you know, there are going to be hurdles to get over for certain populations. You know, you mentioned some of the elderly populations, but even again, some of the research that we've done, you know, if the experience is done right, it's not a Herculean effort to get over, right? We're not asking, you know, an elderly population to learn how to code in Python to build their own machine, right? That's just not how this works. Instead, you know, many people are used to using smartphones. This is sort of taking it one step further and saying, let's integrate that within our healthcare experience. I think, you know, like Ashley mentioned, when you start blurring the lines of the demographic areas, both age and then location of where people live, when you start thinking about the potential for lowering costs, the potential for amazingly convenient access, and then this experience that is far more simplified than what many have been used to and what many have grown up with, I think it's easier to overcome those obstacles of saying, well, this is how you're going to be interfacing now than a little bit differently than you did, you know, a couple of years ago. To your point, Jessica, I think anything new in healthcare, of course, we should be skeptical. But I think, as I mentioned before, this has been a gravitation towards these models. This isn't in one fell swoop, all of a sudden, you know, overnight. Now we're seeing, you know, providers in a materially different way. So I think we are very well prepared as a society to continue to go in this direction.
Faye, I know so much of the care that you provide is interfaced with in-person care. I mean, so there's an aspect of this that's virtual, but not entirely. And I'm curious, how does Firefly see through the quality when you don't control every aspect of the delivery? Like, how is that something you're able to overcome as you move further into, you know, a platter approach of what is available, a menu?
Yeah, it's a good question. So I think, to be clear, when you join Firefly, and whether it's a health plan in partnership with a plan, or whether it's our own Firefly health plan, or you're accessing our care via an employer or a plan, you have your own, and you get to select your own dedicated care team. And this team sticks with you. It is always there. And it is a team-based model. So it has your MD, your MP, behavioral health specialist, health guide. And this team is not only providing all of the primary care, behavioral health, low-level specialty care needs, but also navigation. And it is that navigation component that's really important. We've built a real robust data-driven approach to navigation that pulls in external cost, quality, member experience, and availability data that we use to inform where we're guiding members to high-value providers. And because of the trust that we built with members through our continuous longitudinal engagement with them, they really follow that guidance, and they end up going where we're sending them. And that means, you know, that is one way that we're really able to control for the quality, is ensuring that we are navigating to high value providers. And rather than trusting any single source, because good luck finding that singular source of quality data, we take a composite approach, and we have several different data partners coupled with our own claims experience and our partners' data in order to inform that. And we also get feedback from our members and continually update our provider directory in order to inform that. So that's on the specialty navigation side. And that is a really important part of how we're able to drive savings, because while primary care is, you know, overall a small percentage of the overall spend, it does control and dictate vast majority of the downstream specialty spend. And that is, you know, really how we're doing that. We're also avoiding a lot of unnecessary visits, a lot of unnecessary specialist visits altogether by either doing them ourselves or recognizing that you actually don't need that specialist visit. You actually don't need that surgery. So we're seeing, we really measure avoidance as well. And then when you think of the care that needs to be done in person that you typically expect to be done within a primary care doctor's office, the way that we've solved for that is through a network that we call our Firefly Nearby Partners. And we've built out a network of more than 2,000 tightly integrated physical facility partners and in-home care partners that include urgent care, retail care, in-home care, some multi-specialty practices across the country. And these are tightly integrated. So when you show up, they're expecting you, they know what you need. And whether it's an abdominal exam, a physical exam because you have abdominal pain, or it's a POC test, or whatever that is, as soon as it happens, we're following up with you. We're paying for those services. So there's no financial exchange between the member and that individual. So it really is all part of the journey. And it's one way that we're able to really improve the member experience, but we're also able to provide the same really comprehensive care coupled with the convenience. Usually you have to choose. Do you want the convenience of telehealth, or do you want, comprehensiveness of an in-person traditional bricks and mortar clinic? And we really tried to bridge that gap through our Firefly Nearby Partners.
Ashley, you talked about how this is a provider directed kind of experience for the member rather than a insurance product that they select at the outset. And I am curious if that is enough to make a difference on cost, or does Blue Cross eventually need to go more in the direction where someone is locked into a virtual first plan for the duration of the year to truly make the most cost savings? Like, is this a stepping stone to where we need to go to make the most difference on cost? Or is this enough? I mean, we talked a lot about the cost savings this model already provides. Maybe that's sufficient.
So I don't know, but I think we're going to learn. I think, do I think that that if one was in a more tightly locked, I'll call it a high value plan design, the cost could come down? Yeah, probably. But we also know that there's reticence on behalf of patients, on behalf of members, to lock themselves into that. And when you're locking yourself into something that frankly transformed over the course of a couple of years, what we do know from our member research is they don't necessarily at this point want to lock into that. Now, if I could, as a consumer, if I could say, if I lock myself into this more sort of high value restricted network, that's going to result in a dramatically different deduction from my paycheck each month. I might want to make that choice. And if members, indicate that, and employers indicate that that's a choice that they want, wow, to have options like Firefly to be able to incorporate into that future network would be great. And we think holistically beyond primary care. We have had conversations and added providers to our network in the virtual musculoskeletal, GI, reproductive health, and diabetes spaces. So do I think that's the future? I think it may be the future, and I think the affordability crisis we're in may drive us towards that. Just like the pandemic aligned the forces to allow this conversation to happen, right? Because it's not just about what patients might choose. The medical community had to be structured and willing to engage in delivering this care this way. And I'd say prior to the pandemic, there was certainly teledermatology. There was telehealth with respect to urgent care. There were filling gaps, right? Gaps created by the fact that I couldn't get a PCP appointment 4 hours from now, and my alternative was to go to a expensive and frankly very inconvenient emergency department, and I was the doctor you would see when you came there. And so some of the urgent care telehealth filled that need. But I think today providers, necessity being the mother of invention, they had to learn how to deliver care via telehealth. We created, encrypted, safe Zoom platforms and other telehealth delivery platforms that just didn't exist prior to the pandemic to be able to meet that need. And as a result of that, people got used to it. Providers got used to it. They saw the value in being able to do this. And as Kay said, to use the word virtual first. I mean, if I looked ahead to the future, I would say, what if every practice in America was delivering care along these lines? Some will be tilted a little bit more towards in-person care. Some may be tilted completely towards virtual care. I think we demonstrated in the pandemic that an awful lot, a very, very, very high percentage of mental health care can be delivered this way. Obviously, 0% of taking your appendix out can be delivered this way. But there's going to be this gradation, and I think it may, as Kevin alluded to, some of it may layer out along demographics, and some of it may layer out along preference. We'll see. But I think I think we're going to see a continued evolution of this over time, and it will find its path. And affordability and quality and preference and experience and delight in both receiving care and the delivery of care are all going to be strong factors in how that evolves.
Ashley's comment around choice, I just want to strike that because I think it's incredibly important. And we have really interesting precedent within the benefits ecosystem of employers opting to remove choice, right? So we all remember full replacement, high deductible health plans reaching a point of near saturation where many employers said, this is the only thing we're going to offer. And then they sort of walked that back a little bit and said, no, we'd actually like to offer choice because what our employees continually ask for is choice. So, Ashley's comment about choice rather than forcing, especially as we're looking for emerging models and steering people to greatest efficiency, there still has to be a level of choice. And I think that's what a lot of our clients and organizations we work with time and time again are asking for.
Yeah, and I'm going to piggyback on both of those, but both of what both of you have said. And I think I'm going to hone in on both the affordability and the choice component. I think affordability is really important, and thinking about it from a member perspective. When we talk about total cost of care, of course, equally important, but we're really talking about total cost of care for you, payer or employer. But having that actually translate into reduced premiums for the member makes a really big difference. And we recently, on the Firefly Health Plan, went live with one employer where it was the affordable plan option, but it also feels like a platinum type benefit because the Firefly plan has a broad national network. So you do have choice of provider you can go see, but you're incented to follow our guidance to high value providers. So really creating the choice at the level of specialists and individual providers you can go see. But also for this particular employer where it was a slice offering, so Firefly alongside another BUCA, there was choice of, this might work for some, it might not for others. It ended up that of those going through open enrollment, close to 70% actually opted for Firefly, which was honestly shocking, shockingly high. But I think that some of what we heard was that it was the affordable plan option. So it was really attracting frontline employees and second shift workers. And at the same time, given all of the benefits, the access to other virtual specialty solutions, condition-specific digital health solutions, your own dedicated concierge care team, they had the vast majority of their executive team switch to it too. So it's this really interesting design that can attract both sides of a population in a pretty unique way.
Faye, you mentioned something I just want to follow up on too, which is, the incentive, the idea of a carrot to move people more toward a more affordable offering. And it's interesting because, for so long, the market used high deductible plans almost like a stick. Like if you don't shop around, you're on the hook for it. And I think what I've been hearing a lot is the reason it didn't work is because people can't fundamentally shop for healthcare. I remember when I was pregnant, just trying to shop around for an ultrasound, it was impossible. I needed the provider code. I needed to know the facility fee. They didn't have the code. I need to go here. I mean, it was literally impossible. I'm a healthcare reporter. I couldn't figure out the price of the ultrasound. And so I'm curious, Faye, like, does the navigator part, is that what's been missing this whole time? Like, you can't have a market for healthcare because there is no price transparency. But if you have a navigator that can move you, that's the missing piece?
I think that's a really important piece. And I think actually going a step further and surfacing the why behind the navigation. So actually showing the cost, quality, member experience, availability data that's informing that navigation, but then not putting the onus on the member. I think where things have fallen short and where friction arises is when, it's great to have all the information, but it's a pain and it's hard and it takes time to then, go sift through it and make sense of it and figure out what to do. So I think, empowering the member with the information and helping them understand the why behind a recommendation is really important. And I think that, garners additional trust and ultimately follow through. But I think not putting that the onus on the member and having a navigator there to quarterback the referral and do the guidance is really important.
I want to talk too about the pandemic and the effects of the pandemic before we move into audience questions. Ashley, you talked about kind of the things that Blue Cross did in the aftermath of the pandemic to make virtual care work. And has that really moved the ball forward in this arena? Like, were it not for those things, do you think we'd be so far along?
Yeah, I mean, I can't answer that question without also keeping my provider hat on and my 30 years of experience delivering care. I think it really was that as the catalyst. Sometimes it just takes a catalyst for change, or you need 8 of the 10 rowers in the boat rowing in the same direction to move something forward. And I think what this did was a few things. And speaking with some of our mental health providers, they often shared space in a small waiting room that was like an 8x8 office, and in a residential building sometimes where there was no ability to socially distance. There was no ability to put the infection control protocols in place to clean that waiting room every time somebody was rotating through. And so they had no choice but to move to their home offices sometimes, and they figured out how to make that work. I think the same thing was true of primary care. Sadly, it was multifactorial, right? There was a reticence and a true fear to leave the home, so patients weren't coming in. There were many of my colleagues faced those same challenges in primary care practices. They had to figure out how to care for their patients in a different way, and that forced embracing technology. It forced changing your processes and changing your operations to be able to kind of work that into your daily workflow. And whether that was, driven out of, I think what all healthcare providers come to work to do, which is to care for people because they care about people. But there were also financial components to this. They had employees and they had staff that they had to pay who were dependent on them for their livelihood. So they had to figure out how to do this. And honestly, in sort of how medicine has traditionally evolved, it's been slow compared to the innovation we see in tech and in other industries. That moved at a very lightning speed out of that necessity. And we started as providers, I think, to embrace there is a different way of doing things. And it caused me to reflect 30 years after medical school, what I remember being taught in residency, that 80% is through the conversation. Well, I can have that conversation as you and I are having that conversation today. So let me figure out how to do that in a different way. And so I do think that was really a critical part of it, where sometimes the forces just all align in a way that allows something to move forward. As opposed to the push me pull you of the forces can often be, where you're not really sure that you're actually moving anywhere other than in multiple directions at once.
Yeah. Kevin, I want to talk too about the broader context. Not only have we had the pandemic that's really perhaps opened people's eyes to the possibilities of virtual care and virtual first primary care and virtual first more comprehensive care. But you also have an environment where there's increasing competition in this space. I mean, and people have an expectation. Well, like if the big names out there, the Amazons, Walgreens, CVS's are moving into models that include virtual components, like has that also opened up employers' perspectives into what should be available in the market, what they're willing to participate in, or has it really been the pandemic that's been moving things along?
I mean, I think, Jessica, the pandemic shined a rather unfortunate light on a whole bunch of things in this nation, right? Inequality, affordability coming out of the pandemic and having rapid inflation, healthcare inflation, unemployment issues, wage growth issues. And Ashley and Fable talked about it, but we're in a situation where a lot of people don't have primary care physicians, don't have access to primary care physicians. 100 million people live in a health provider shortage area as designated by the feds. I think what we're seeing coming out of the pandemic is, again, as I mentioned before, a willingness for people to gravitate towards these solutions. And I think to more directly answer your question about some of these, amazing organizations who are diving into virtual care or adopting virtual care. I think we've seen this time and time again with any type of newer healthcare models, health tech models. There's going to be early movers and there's going to be fast followers, and then there's going to be late followers, right? And so I sort of view us on the bit of the crest of the wave right now. There have been some early movers, and we're going to soon see a lot of fast followers because I think they're recognizing the value that these models can bring. And there are some, to your point, very big names that are now touching this space, maybe not directly on this topic, just virtual care more broadly. Again, even reading the chat, from AI to remote patient monitoring to sort of the emergence of point solutions in and out of network, I think have all led to this convergence of additional focus on virtual care. So hopefully that answers your question.
Yeah. I want to get to some of these audience questions, and Faye, I think I'm going to direct the first one to you. So someone asked, like, what barriers still exist? What's the required investment, to move things forward? And another person asked about lack of broadband access in many rural areas. I don't know if that's like one of the areas of investment that's needed to move this forward. But what are the kind of hurdles that still need to be overcome to really put this at scale, make this an offering that everyone, it's not just a new experiment or new offering, but the status quo?
Yeah, I mean, I do think that virtual care, when we think about access, but also equity, I do think that just virtual care is a really great way to provide equitable access to members and employees across the country. And unlike a physical practice that is rooted in a singular location, you're able to provide the same level of care and access through partners to really everyone across the country. It's been really exciting to see with even just Blue Cross of Mass, our partnership, the huge percentage of members outside of the state and concentrations in more rural areas. So right now, close to 60% of Blue Cross of Mass members are outside of Massachusetts. And then you look at where they're located, and there's real clusters outside of those core metro areas. So I think that that is just sort of a baseline for access. I think when you do think of places without broadband access, we do have phones. It is not the same experience as being able to access the full Firefly Health app, but I think that is, a default and an important one. And also for different populations who aren't comfortable using an app, and senior populations, as you think about MA, having that option is really important. And actually many virtual care solutions do not. And it's amazing how just simply having phone as an option has been really important. You're not going to be able to replicate the same level of experience, but it is still an access point.
It's a different problem to solve, Faye, too, I would say, right? I was trained in Canada, where 85, 90% of the population lives within 100 miles of the US border. There were incentive programs back in the 80s to try and incent graduating residents such as myself to live in rural Canada. It's a whole different conversation when the intervention and the incentive program is to get broadband access to rural Canada or rural America than it is to try and move the providers into those spaces. We've tried to do that for decades, and we haven't been fully successful. And we're doing it with a lot of headwind, right? Decreasing number of providers, and providers not working as many hours as the people who trained me were willing to work. So it's dynamic, and they're all forces that are interacting with each other. But I'm much more encouraged about solving a broadband access issue in the country than I am about the success of encouraging our graduating fellows from academic centers that are largely in very urban parts of the country to move to some of the rural areas where this care is desperately needed. And that can be accomplished through virtual care and broadband access. I think more readily than trying to cause population shifts.
There's more questions that we're not even going to get to, but I have been told that if we didn't get to your questions, we will get back to you after the fact. So don't think we've eliminated your questions entirely. But I wanted, as we wrap up in the last 10 minutes, to ask each of you to kind of manifest for me. Like, let's put this out into the universe. If your vision, what is your vision for a productive care delivery model? And if it came true in 5 years, what would it look like? Kevin, let's start with you.
So we've talked a lot about value and we've touched on risks. So first and foremost, my vision for the most productive care delivery model, first and foremost, is one that has truly shared risk, upside, downside risk, where every party who's involved recognize they have something to offer and they're willing to put up something. So from the payer, the provider, and to an extent the member takes risk every single time they talk to a physician, every time they talk to a provider. And then we'll talk a little bit about this too, but true connection, a connected ecosystem whereby patients, providers, payers all speak the same language. And that's from the EMR, right? Having a consistent EMR to connectivity through, Faye talked about navigation, and then a model that thinks about the whole person, right? Not just the patient, but the patient and their family and their community. Again, not to beat a dead horse around the pandemic, but shine a light on massive inequalities and community level issues that when you think about the patient, it has to be the entire patient, their family, their community, how they access services that are healthcare and healthcare adjacent. So big feat, right, for something like that, right? But that's sort of what I would envision and hope for, Jessica.
Hey, manifest it. Ashley, how about you?
Yeah, I would say that, and that interconnectedness, that we've built a model that allows those seamless transitions, that creates the access, but also restores some of the delight and the joy in receiving care, so that patients, members feel that they're not only cared for, but cared about, and they can feel cared about through that team-based care, that high touch, that circling back to make sure that people have what it is that they need. And I think the health plan has a role in curating that. And I think the health plan can have a role in helping members navigate to that care, and helping them identify what will work for them, and whether that's a strong, existing traditional network of care. But 5 years from now, I'd like to see that we're not even having that distinction, because the kind of model that Faye's leading the charge on here has got wrapped around its specialty practices that are functioning in that way as well. And they're seamlessly integrating and meeting people where they are, for people that have a more heavy need on in-person care, or seamlessly flowing back and forward between them. That's what I hope for the future. And I hope that ultimately that's all driving towards better outcomes, and more people have got their diabetes reversed or in control, their chronic GI conditions, which are just so difficult to treat in a disintermediated system. Those symptoms are under control, and people have got the access that they need to the care that they want and deserve, when and where they need it and want it.
And Faye, how about you? 5 years into the future, manifest your vision.
So completely agree with what both Kevin and Ashley said. I would say that in 5 years, I think the biggest change is that, really the future is an asset. There's an asset light front end that's attached to all forms of care delivery. And it's tightly aligned to a payment model that prioritizes outcomes for members, all while decreasing costs for payers and individuals. So in other words, I call it an asset light integrated delivery and financing network.
Damn. Well, these are some lofty goals, but ones that all of you are progressing and fulfilling each in your own roles. And so I'm excited to see where things take us. We do have 5 more minutes. I'm wondering if we can get one more question in here from the audience. Someone had mentioned or asked about specialty care. Is there a role here through an integrated experience to move more specialty care into a virtual model? This question is for any of you. Or maybe that's already happening. This person mentioned rehab for stroke, multiple sclerosis, pelvic floor rehab. Is this further?
Yeah, those are all great examples that you've just pointed out there in the rehab space. But I would say it's more than that. I take it back to my conversation earlier around particularly mental health, right, lending itself to that virtual interaction. But I think there's strong promise in musculoskeletal care, in sort of reinforcing rehab and physical therapy. I think I mentioned the chronic GI conditions. We've got provider groups out there that we've partnered with, such as Oshi Health, that in that same collaborative advanced care model, they're bringing together psychologists, dietitians, and GI specialists to be able to manage those complex conditions. I think the same is true of diabetes care. There will always be an element of diabetes care that can and should be managed within a primary care practice. But as I think about what's needed for advanced primary care and virtual model primary care to be delivered, there are these virtual specialty care services that need to be wrapped around to support that. And there's also in-home care that needs to be available there. Home infusion would be a great example of that. So I think there's tremendous opportunity in the musculoskeletal rehab space. I think in the diabetes space, access to virtual doulas and the care during maternity with entities such as Maven Clinic are other opportunities. And ultimately, I think the care delivery system is going to define and titrate how much of each one is appropriate. But sort of my conversations with Faye are, what do you need to be what do you need to be successful in virtual primary care delivery? Because that's probably where I should be looking next in specialty care delivery, and that's in turn driving our Blue Cross strategy around the virtual specialty care providers that we're looking at and engaging with meaningfully.
Yeah, and strongly agree. So we actually partner directly with several condition-specific virtual specialty care companies. And some of them that were our partners are now partners with Blue Cross and Mass, Oshi being a great example. And we have partners across about 12 different areas where we believe that, a virtual modality can really drive a strong ROI, better clinical quality outcomes, reduce total cost of care. And we really prioritize models that are aligned with the Firefly model, which is, that longitudinal model of care and really value oriented.
Excellent. Well, I'm excited to see where each of you take this, how far you progress things. I'll be checking in 5 years to see, how far have we gotten to this vision that you guys have put out in front of us. But I think for all of us here and everyone listening, we certainly have a directive of where to go, understand the promise, and appreciate the challenges in front of us to getting there. As I mentioned at the onset, if we didn't get to your questions, Firefly will be following up with you directly to touch on them. I wanted to thank all the speakers for your time and expertise. This has been a really great conversation. And thank you all for having us. This has been great.
Thank you to our speakers and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Los Angeles, February 25th through 28th for VIVE 2024.